Everyone. Good morning. Good morning. Thank you for being here so early in the morning. I hope you had an easier time getting on than I did. I feel very popular at 7 in the morning as everyone's trying to figure out where everything is in my house. Good morning. Welcome to our third in a series of webinars for the Washington chapter of the AAP, our Equitable Care Work Group. My name is Kathleen Kieran. I am one of the co-chairs of the group, along with Dr. Peter Asante, who will introduce himself in a minute. And we are here today for part 3, which is safe and reliable care. You can go ahead and advance the slides if you'd like on there. So today we're going to be talking about a little bit of background for those of you who are not familiar with our work group or the work that we've done, specifically the Equitable Work Group Equitable Care Toolkit. We're going to talk about safe and reliable care. We have a couple of guest speakers, and they're going to be talking about structural racism in clinical practice. Next slide. All right, so the background, for those of you who have been to our other webinars, you are probably familiar with this already. But several years ago, we actually had the idea for this work group, as Dr. Sante's baby. And certainly with the events of last spring that caused a national reckoning about racism and equitable care, this really moved this forward and made this work a bit more urgent than it had been in the past. So the Washington chapter of the AAP and its members collaborated with a selected group of people. We actually had to apply to establish a toolkit. The goal of this toolkit was to help healthcare providers and all those who care for children and their families to be able to provide equitable care, to make care more welcoming and responsive to families of color, and in particular to deliver high quality care to the patients and families we serve within Washington State, recognizing their diversity and their unique needs. And then it's available on the website. Clearly that's a link, but if you go to the website, it is actually one of the highlighted areas on the website. You can download it, and we are constantly looking at it to update it as well. We're very open to feedback. Next slide. All right, so today we're going to be talking about safe and reliable care, and this is one of the 4 buckets of the toolkit. And so what safe and reliable care means in practice is education on the evolving and specific and unique needs of our patients, their families, their caregivers, their groups. Oh, thank you for putting that the toolkit in the chat as well, Ahmad. Within safe and reliable care, you can see on the right side, I know this is faint, but I promise if you go to the website, you can look at this. We have questions that are done in basically the CME board style that will help you to think about these clinical questions, these clinical vignettes in a way that help you think about care for patients in equitable, culturally sensitive, culturally aware ways for your pediatric patients and their families. And our goal with these questions with the toolkit in general is to promote skills in reducing health disparities in one's clinical practice. I think we've all been in the situation where we've said, I can't be the person who's providing not equitable care, and the data would suggest that there are certainly opportunities for improvement. So this is a way to help clinicians think about the care that they're providing, how they may do things differently. Next slide. All right, I'm going to turn this over to Peter for the next slide, and you can take it away.
Hi, good morning, everyone, and thank you so much for being here with us. And Kathleen, I'm so glad you were able to join us.
Me too.
So it is my job to let you guys know that our next webinar is going to be on Wednesday, December 8th, which is titled Promoting Equity, Diversity, and Inclusion in Healthcare Organizations. For this talk, we'll actually be having a panel of I call them healthcare institution juggernauts within the Pacific Northwest, to talk to us a little bit about ways in which they have implemented change within their own organizations, and also major wins and challenges to the process of creating a more anti-racist organization. And so we hope that you guys will be able to join us. We know that it is less than 3 months away. That was because we wanted to protect people's holiday breaks, whatever that looks like. So yeah, December 8th. Next slide, please. All right. I have the privilege of introducing our speakers this morning, who are very accomplished, and by their age, I don't think I was nearly as accomplished. So it is a real joy to introduce them and let them take this away. We're going to start first with Angela Zhang. She graduated from Duke University in 2015 with a
Did Peter freeze, or is that just me?
He's frozen.
Is that better?
Yes, go ahead.
Sorry, this is what happens when you live in rural Washington and you think you have good internet and you don't. So I don't know where I left off, but I will start with she attended.
You just started introducing Angela.
Okay, well then I'll start over.
Yes.
So she graduated from Duke University in 2015 with a self-designed major in mass media and cross-cultural perception, focusing on media bias and the immigrant experience. She attended medical school at Brown University and became involved in advocacy around incarceration health, climate justice, and reproductive justice. After her clinical clerkships, she took a year away from medical school as the selected fellow for the school's Office of Diversity and Multicultural Affairs, working in anti-racist medical education, dismantling biological recruitment, medical education, transitions of care, health journalism, and gastroenterology. All right, and then for our second speaker, this is Naomi Nkinsi. Naomi graduated from the University of Washington with double majors in cellular, molecular, and developmental biology and public health. After graduating, she worked as a research technician at the Fred Hutchinson Cancer Research Center, where she conducted studies to identify potential drug targets to treat small cell lung cancer. Currently, Naomi attends University of Washington School of Medicine and is also working towards her Master of Public Health in Global Health at the University of Washington School of Public Health. She is a strong advocate for centering anti-racism in medical education and ending the practice of race-based clinical practice, which continues to be common in medical practice today. She has published a paper in academic medicine that outlines how medical education today continues to perpetuate racial disparities in health, and has been featured in NPR and several other media outlets for her continued advocacy work. Naomi is a 2021 recipient of the Paul and Daisy Soros Fellowship for New Americans. And with that, ladies, take it away.
Thank you so much. Thank you for inviting us here. And I'm really honored to give this talk with Naomi. We've worked together for almost a year now. Met in person for the first time a couple weeks ago, and we're excited. Okay, people can see my screen?
Yes, we can see you.
Awesome.
Well, we can see the screen. Go ahead.
Awesome. So today's talk is going to be called Tools of the Master, Countering Structural Racism in Clinical Practice. You already heard a little bit about who we are. I think Peter cut out during this part. So just to clarify, I'm a pediatrics intern here at Children's and University of Washington. And Naomi is a medical student at UW, now doing her MPH here. Before we get started, we do want to do a land acknowledgement. We want to acknowledge that we are on the ancestral, unceded, stolen, and occupied lands of the first people of Seattle, the Coast Salish and Duwamish people, past and present, and honor with gratitude the land itself. I do want to say that this acknowledgement does not take the place of authentic relationships, but is the first step in honoring the land I am on. The QR code are more ways to get involved beyond acknowledging land. Some of the things I'm doing, I'm reading The River That Made Seattle about the Duwamish River, as well as getting involved with Indigenous organizations, and I encourage you all to do the same. This presentation will entail visual slide content and uncaptioned audio on Zoom. We will not be asking you to stand or move. Unfortunately, there will be no closed captioning or transcript at this time. I also want to encourage you all to take note and reflect on any discomfort you should feel today. Naomi and I believe that anti-racism training should be uncomfortable, and we should be reflecting inwards and adopting a growth mindset. This quote is from a really big role model of mine, Audre Lorde. She writes about how the master's tools will never dismantle the master's house. And then, you can read the rest of the quote for yourself. And this is really about how true change comes outside of the system and from those who've been marginalized at the outside of the center. For today's talk, I would actually encourage us to think about using the master's tools to start that dismantling. We'll kind of be talking about what those tools are today.
All right, so before we discuss race-based medicine, we think it's really important to kind of talk about the multiple forms of racism. And we know that you've had previous talks that went into what is racism, but we think it's really important to point out that there's many different forms of it. And oftentimes what I hear from people is they think of racism as more interpersonal. So things like slurs or bad interactions with individuals from minoritized populations. But it's important to remember that even if you are, the most anti-racist person that you could be in your interpersonal interactions, you still exist within a framework of racism within our society. So it's important to understand. So there's different forms of racism, such as internalized racism. An example of this would be colorism within minoritized populations, where light-skinned individuals are given more privilege than darker-skinned individuals. Structural racism, like the fact that factories that produce pollutants are more likely to be placed in areas that house more marginalized populations. Institutionalized racism, like we've seen with police brutality against Black Americans. Cultural racism, such as the belief that Black Americans are more likely to have diabetes solely because of diet. And then, of course, interpersonal racism. Next slide. So within this framework, thinking about racism, we think it's really important to think about critical race theory in medicine. So it's important to remember that critical race theory is a legal and scholarly theory. And there's a lot of controversy right now about critical race theory being taught in schools. But for the purposes of our lecture and for medicine, we see critical race theory in key points. Race is a social construct, not a biological phenomenon. Racism is endemic and ordinary, not aberrational. So it's key to our job as providers to advocate for our patients within a racist system. And perspectives and lived experiences of racial ethnic minorities are central and essential. So in the clinical context, this means that lived racism is an important mediator of disease outcomes. And also remembering that just because someone studies racism and studies the experience of marginalized people, you do not have the same expertise as someone that has that lived experience. And finally, that race and racism should be considered within a cultural, historical, and contemporary context, and that dominant society racializes individual minority groups differently, and that the needs of these groups can shift. Next slide. So when we talk about racism in medicine, often what we are taught are these three very specific examples. And I want to go through them briefly. And then Angela will talk about how racism in medicine isn't just three distinct examples, but actually an entire timeline and progression within our medical system. So the first example is Dr. J. Marion Sims. So he's considered the father of modern day gynecology. He developed and pioneered tools and surgical techniques related to the reproductive health and was named president of the American Gynecological Society in 1880. He has half a dozen statues across the country, many of them located in front of hospitals. He was known for perfecting his surgical techniques on enslaved African women without anesthesia. And then once his techniques were perfected, he would perform these same surgical techniques on white women with the use of anesthesia. Some of his subjects, including a 17-year-old enslaved woman, endured as many as 30 different surgeries. The next example is Henrietta Lacks, someone that I'm sure most people are familiar with by now. She was a Black woman born in 1920 who presented to Johns Hopkins Hospital at the time with what was determined to be cervical cancer. Her cells were found to be unusual in that they could replicate pretty consistently. And these cells were then known to be called the HeLa cells, which is an important cell line in many discoveries and scientific advancements, such as the polio vaccine and even other discoveries being made today. So it's important to note that her cells were harvested from her without her permission and without the knowledge of her family or herself. The other example that's often discussed, especially in the context of COVID and vaccine hesitancy, is the Tuskegee syphilis study. So this started in 1932 by the Public Health Service in collaboration with Tuskegee University, which was a historically Black university. They enrolled over 600 impoverished sharecroppers, some with latent syphilis and some without. The men were promised free healthcare, but in reality were not actually treated for their syphilis. This is despite the fact that penicillin was widely available and known to be curative. The study was told to the men to be going on for 6 months, but extended to over 40 years. And 128 of the participants died either directly to their syphilis infection or to complications of the disease. So again, these are three distinct examples that are often cited when we talk about race-based medicine and racism in healthcare in the US. But the roots of that are much more insidious. Next slide.
So like Naomi said, it's easy to think of these as aberrational and things that we would never do today, but I think it's really important to take a step back and think about how echoes of this are still in modern medicine. I'll start with the 1800s, but we all know that this precedes this, and we just don't have documentation right now. So we can think about Carl Linnaeus and Samuel Cartwright. Linnaeus categorized races by 4 distinct qualities. For the sake of time, I will not go into those, but they had different qualities and were clearly ranked in a hierarchy. Samuel Cartwright wrote the report on the diseases and peculiarities of the Negro race in 1851, with such things as drapetomania, which he named as the disease of wanting to run away. He would actually prescribe things like whipping or cutting off of a toe to prevent slaves from running. In the 1900s, we have things, and to just reiterate, these were very respected scientists of the time. This was not some sort of fringe idea, but these were widely respected, published in literature, and then thus passed down. We have craniometry, which was using skull measurements to rank brain size and intelligence. The intelligence quotient used to justify eugenics of the disabled and prohibition of interracial mixing. We see echoes of this in standardized testing today in the SAT, ACT, and the MCAT. So thinking about how medicine perpetuates that. Body mass index was invented as the ideal man using Scottish and Irish men. It was never meant to be a marker of individual health, but actually was pioneered as such by insurance companies. It influenced the eugenics movement, and we've all used BMI in visits, and I would encourage us to think about the racist origins of that measurement. There's the example of hair types, where colonizers viewed indigenous grooming rituals as proof that they were irrational and ungovernable, partially justifying enslavement and genocide. It came to symbolize savagery and degeneracy and proof that races are biologically different. So what will we look back on in the next century as science that is pseudoscience and perhaps aberrational, but respected in its time? The Human Genome Project came out in the 1990s, was a huge milestone, and I think a really valid contribution to science. The report said humans are 99.9% genetically the same, and the 0.1% difference is not noted between different racial groups, rather within them. And so this is not to say that genetics as a field is illegitimate. I think there's much we can learn from this field, but with the failure of precision medicine to come up with individualized therapies in 2021, I think a lot of the medicine has turned to finding differences in that 0.1% within racial groups. The NIH actually allocates almost 500 times more money to studying genetic sources of disease than studying social determinants of health and ways that we can actually affect health outcomes of marginalized populations. And we'll be focusing today a lot on race-based clinical algorithms. So how I produce knowledge about race matters. This is a graphic from a paper about the genetic structure of Africans and African Americans. You can see on the left here that these colors cluster by what appears to be different continents. So I see African Americans as well as Western Eurasians. So you can see that if your scope is worldwide and you delineate those categories, then you will see variation. On the right, you'll see that the scope is much smaller. These are limited to specific groups within the continent of Africa. And you can also see this variation here. And so we can think about Dorothy Roberts, who writes about when researchers tried to cluster groups in the Genome Project. When they chose 6 groups to cluster, they found 6 genetic clusters. So you could think, well, race then does have boundaries. It does have, static characteristics, but then when they try to cluster into 20 groups, they also found 20 clusters. So we only answer the questions that we ask. And I think based on the disparate funding, we are asking the wrong questions. Where does this play out in clinical algorithms? In pediatrics, we can think of the UTI algorithm, which recently removed race, which I commend the authors for. The asthma step-up therapy in the New England Journal of Medicine, bilitool, which we'll go into, and the many diseases which have, quote, racial predispositions, which are false and actual proxies. Of course, our pediatric patients grow up into adults, and then they'll face many, many more race-based algorithms. Individually, each of these might not cause irreparable harm, but we have to think about these as further encoding race as immutable and inherent, instead of as a social construct and the lived experience of racism. So let's go through some case studies of those algorithms. The first one is pulmonary function tests, or spirometry. The spirometer was used by Samuel Cartwright. He studied healthy white soldiers and Black slaves and measured their lung function. As you'd imagine, based on the unhealthy conditions of working in the fields and the unhealthy conditions of forced enslavement, the Black slaves had lower lung function. He then determined that this was actually inherent to being Black, and he and Thomas Jefferson used this to justify further enslavement to build up vital capacity of Black people. We use the same correction today. And in fact, based off of that, people have tried to find other racial corrections. So using 2 studies with small n's to think of an Asian race correction. We use this correction in cystic fibrosis to measure patients' clinical progression. There have also been cases of workers' compensation being denied to Black workers because their baseline lung function is, quote, lower. I'd also like to note that spirometers are different by manufacturer and by country, based on the political and the private interests of that manufacturer. And so questioning that the racial categories can be changed by country feels like a fallacy. On the right, you can see an example of a spirometer. So in order to run the test, the technician must choose race 1 or race 2. I believe this spirometer is Black and non-Black. There are other spirometers that have options for Mexican, for Asian. On the left here, you can see instructions for technicians from the 2003 edition in the UK to train spirometry techs. They instruct them to just observe people and document their race. If the person does not want the race to be documented, you can just use unknown and use Caucasian reference equations. The fact that it can just be that casually thrown aside to me feels like it must not be scientifically precise as we imagine it to be. Kind of going back to studying race as inherent and failing to study other factors, Dr. Braun, she's a really big person in the field of PFTs, and I was really lucky to work with her at Brown, did a systematic review of many articles looking at spirometry and saw that race or ethnicity were rarely defined in these papers. Most of the papers failed to examine socioeconomic status, something that actually may contribute to lower lung function based on somebody's environment and structural determinants. And few of them actually cited these factors. The next case I want to go through is hyperbilirubinemia and East Asian race. On the left, you'll see this is a list of risk factors from Billy tool. I will note that there are other tools out there like NCNC that do not use race. This encourages people to consider East Asian race as a risk factor, hyperbilirubinemia in the newborn period. Not only is this in the algorithm, but it also perpetuates throughout respected medical literature. Here you'll see a blurb from Up to Date, a well-respected clinical encyclopedia of sorts. And they talk about this gene that's present in Asian populations. If you follow these references down, reference 12 is actually a case control study in Shenzhen, China, with an N less than 300 for both cases and what they call Caucasian controls. And then they do a review of literature with most studies also having an N of less than 200. I will note that we do not use the term Caucasian anymore because it derives from eugenicist ideas of ranking Caucasian, Mongoloid, and Negroid bodies. The second reference looks at 42 Japanese newborns and 50 healthy German controls. So as you can see, these N's are quite small. And I think to extrapolate from that an entire paragraph that then is passed down to physicians and trainees is irresponsible. Up to Date also talks about jaundice peaking in different times in different races of infants, drawing from this Pediatrics article. And I think this is a really salient case of just market extrapolation. This paper specifically says that their objective was to document the natural history of jaundice in a predominantly breastfed white population of newborns. And so on the right, you can see demographics. The white infants make up almost 800 of the population. Every other self-identified race, or however they identified them, is quite small. And the objective was never to study race-based differences, but you can see that in the up-to-date blurb, they have taken it and made it race-based. Medscape is no better, although I will give them credit to saying that Greek infants born in Greece have instances of elevated or higher instances of jaundice. And they actually say this might be environmental rather than ethnic in origin. And so I want you to think about the fact that it probably is environmental, it probably is structural and not ethnic or racial, and that they don't apply this reasoning to any other race. They cite this fact that 49% of East Asian, 20% of white, and 12% of Black infants have this high Billy. If you look at this reference, it's from a study in which not only are the N's pretty disparate, but the races are white, Black, and then Oriental. I don't know how they defined it. It's really, they don't say it in the methodology, but you can see how the Medscape authors have taken this and phrased it as East Asian. And if you didn't look at the reference, you wouldn't know that this is actually the data. Lastly, they also talk about this study of Taiwanese infants and this gene as proof that East Asian infants are at higher risk. If you go to that paper, the N is around 100, and they cite their own paper where they claim to compare Taiwanese subjects to white subjects. When you go to that second paper, it turns out they're relying on reported data from 1994. We don't know the methodology for that. And then when I go to the 1994 paper, you just can't find it through any institutional access. So it was a dead end and I couldn't find any of the methodology. And I think all this to say that it doesn't mean that studies with small n's are all illegitimate, but the fact that we've taken these and made them fact in database, and the fact that we've used this as causation and not correlation, and the fact that race here is a really sloppy variable and something we would not accept in any other scientific variable, having been taught evidence-based medicine, is something that I have found pretty unbelievable in doing this work. Lastly, I think we can't talk about this without reflecting inward and reflecting how we can change. In writing questions for the WCAAP question bank, I happened upon this question about an 8-year-old female of Filipino ethnicity. She comes in for a visit and she has, great nutrition, healthy lifestyle. Her parents are both really short, and it asks you, what should you do next? She's a little bit low on the growth chart. And the correct answer is you don't need to do anything. Her parents are short, she eats well, she moves her body. But then the answer throws in this thing about Filipino ethnicity and South Asian descent, and about how patients of South Asian descent tend to be shorter. And that's the whole reason why it's in the Health Equity Bank. I'll tell you, well, first I want you to just see that she's Filipino, and the study that they reference only studies Malaysian, Thai, Vietnamese, and Indonesian children. So already they're extrapolating. Then if you think about the people in these countries, they did enroll many, many children, but looking through the methodology, they never defined how they enrolled people. Did they ask them if they were ethnically Malay or Thai? We don't know. And I'll also ask you to think about the history of colonization and imperialism and migration, forced and voluntary, in these countries, and how all 4 countries have significant intermixed populations from nearby countries not included in the study or considered to be other parts of Asia. So Chinese or Indian or immigrants from other parts of the world. It would be like saying, American-born babies have this predisposition. It's a nationality and a nation state that's modern and doesn't correlate with race or ethnicity. So race is different from ancestry, is different from ethnicity, all to say that genetic variation itself is clinal and is a spectrum and cannot be bound by the sociopolitical boundaries that we have set for race and ethnicity.
So next we want to talk about ways in which advocacy to remove race-based medicine has been able to lead to change, with the specific example of estimated glomerular filtration rate and kidney function. And I think something that's really important to take away from what Angela was saying earlier is we have to think about who gets to create knowledge and how that knowledge continues to be perpetuated throughout our society and throughout our medical system through medical education, residency, and then as attendings in the future. Next slide. So here we have an image of someone's estimated GFR based on the previous GFR calculated by the National Kidney Foundation and the American Society of Nephrology. So you can see on the left-hand side that in patients that have the same serum creatinine of 1.5 and the same age and the same gender, or in this case, what they're really looking at is biological sex. If the person is identified to be African-American, their GFR value is 54, or if they're identified to not be African-American, their GFR value is 54, whereas if they are African-American, their GFR value is above 60. So you may ask, why is this important? Well, the reason that this is so critical is because in adult medicine, there are so many different cutoffs for different medications and treatments and referrals to specialized care that are based on someone's GFR value, which is measuring how well their kidneys are functioning. So if we have, for example, African Americans whose GFRs are inflated artificially, what this means is that African American patients actually need to be sicker in order to be referred to the same type of specialty care as non-African American patients. And when you look at the National Kidney Foundation's question and answer panel for why is GFR different African Americans, it's pretty plainly stated that GFR is altered in Black patients simply because African Americans are thought to have a greater amount of muscle mass. So serum creatinine has to be adjusted. Next slide. So when we think about race-based medicine, again, thinking about who gets to create knowledge and how that's perpetuated throughout our systems, we have to look back at the original studies that defined how to calculate eGFR. So the 2 main studies were the MDRG study, which was conducted in 1999. And in this study, the researchers found that Black patients had a higher level of urine creatinine than non-Black patients. So from this, they made the jump that, well, in previous studies that were conducted using dubious methodology, scientists found that Black people actually had higher levels of muscle mass. So this must be why these Black patients have higher levels of creatinine. So from this, it became fact that Black people have more muscle mass, thus have higher creatinine. Thus, our estimated GFRs must be adjusted to account for this. The second study was the CKD-EPI study, which was conducted in 2009. This was done to be an improvement on the MDRD study. And in this particular study, race was only included per the researchers because the MDRD equation included race. So again, we have a faulty science that created knowledge back in 1999, and then this was perpetuated and grandfathered in to more modern equations. Next slide. So I think when we talk about race in medicine, we have to consider that race is less of a risk factor itself than it is a marker of racism and related exposures. So when we talk about race-based medicine, often the first question we hear from people is, are you advocating for race-blind or color-blind medicine? And the answer to that is no. Race is important because it shapes the way our patients experience day-to-day life. It shapes the way they experience access to healthcare, and it shapes the way that we interact with them as clinicians. So while we're saying that we don't want people to practice race-based medicine, what we're saying is that we don't want people to fall into the fallacy that race is biological, rather thinking about what does a person from a minoritized population experience in their day-to-day life because of their race. Next slide. So when we talk about thinking about racism and race-based medicine and determinants of health, oftentimes we stop at just thinking about these social determinants. So access to safe housing, living wages, quality education, transportation, job security, etc. But what we really need to be doing is looking at one step up. So what determines the social determinants of health? So things like the labor markets, social security nets, tax policies, and then even one step up from that, the roots of white supremacy and racism, class oppression, and gender discrimination and exploitation. So when we see our patients and we're thinking about the social determinants of health, we have to think about these things more globally. How can we better advocate for these patients by looking at the root causes in our society and breaking those down? Next slide. So in the future, what we advocate for is anti-racist critical thinking. So rethinking the ways that we do our research in health inequity, rethinking the way that we do advocacy to transform social systems, looking at, again, those root causes, and interrogating our own roles in racism in healthcare. So like I discussed in the beginning of our presentation, oftentimes racism is discussed as interpersonal racism. But in order to really be a more anti-racist clinician, we have to think about the structural and institutionalized racism in which we operate. So thinking about ways that we can better document health inequity and variation amongst different groups of people, thinking about ways that we can resist framing particular populations as essentially damaged. So in the case of kidney functioning, rather than thinking of Black kidneys as being inherently inferior, thinking about the different strengths of the communities instead. Investing in research and programs that can mitigate and reverse these effects, and committing to asking different kinds of questions. So like Angela said earlier, we're only answering the questions that we're asking. So making sure that when we do frame our research and think of new things to investigate, that we bring those people to the table, looking at the most marginalized in our community and looking to them to be stakeholders and to help guide our research. So in the chat, we'd like you guys to think about different ways that you can pledge and encourage others to think more critically about racism in your clinical practice. And Angela and I will give 2 freebies for you. So thinking about micro and macro aggressions more critically and stepping in and being up standards. And the other response that we typically get is listening and learning and coming to talks like these. So other than those 2 kind of baseline ways that you can encourage others and yourself to move forward, what are other things that you can do? Next slide. So we do have some suggestions. For students, incorporating discussions of racism or dismantling race-based medicine into all of your clinical presentations. So as a current medical student, we often are tasked with giving presentations to our team and our attendings. So making sure that we include incidences of race-based medicine and discuss their history. And then as residents and fellows, being critical to learning critical as we are learning different guidelines and thinking about, are these corrections necessary? What are they really correcting for? And is race being used as a proxy rather than an actual direct measurement? And then attendings, making room for uncertainty and realizing that medicine is learning in two ways. So being open to learning from both your students and your residents and fellows as well. Next slide. And with that, we're happy to answer any questions and take any comments in the chat.
I think I see a question from Catherine.
Hi, can you guys hear me?
Yes.
Oh, hi. So I'm Dr. Kat Trinos. Dr. Zhang, I wanted to thank you wholeheartedly for calling out my health equity question bank question, by the way. I wrote that question. I don't think I'm breaking any HIPAA laws. It was actually my niece who endured that experience. And as I was writing the answer, Dr. Zhang, I was really struggling on whether or not even to put a reference there, because unfortunately there's nothing, there's no study, there's no journal article that, you know, simply states, you know, when two parents of any ethnicity are shorter and their child is, you know, below the 3rd percentile, you don't need to, you know, you don't need to refer them over to endocrinology. And unfortunately, on the Seattle Children's website, one of the reasons to refer your patients to endocrinology is if they are below a specific percentile on their growth curves. And so I guess one way that I think I'm going to move forward and challenge the system, thanks to you wonderful, wonderful speakers, is I'm actually going to challenge that, that particular statement in, you know, on as far as reasons to refer my patients, because it does draw in a lot of patients then whose parents are, you know, both, you know, mid-parental height goes below, you know, the 3rd percentile, in which case would be very normal for that family. But yet, you know, a lot of patients might end up being referred for that reason. I think what's fortunate for me, of course, being, you know, I mean, she's my niece, she's my family member. You know, I'm well below the 3rd percentile. This appears normal to me. What I'm hoping is that everybody else on this call who, you know, may not be of Filipino descent, may not be familiar with, you know, normal growth being less than the 3rd percentile in a lot of our families, hopefully don't make the mistake of sending those patients for referrals, because that was actually a very traumatic experience for her. So.
Yeah, thank you so much for bringing that up. And I think I'm really appreciating that we can have this conversation here. And I think that that is such a great, well, thank you for advocating for your niece. I think that's such a great, great example of how it's really hard to operate outside the structures, right? If our hospital's guidelines are telling us to do one thing, then it's not, you know, it can't, it's not, the blame is not on the individual for following that guideline, especially trainees and people who are really learning the discipline. And I think what you said earlier really resonates with me. There's no data on should we be referring to endocrinology if parents from any background are below a 3rd percentile. And to me as a trainee, that's the question we really should be asking. But instead we have these studies about race and ethnicity that are for proxies. It doesn't mean that, you know, the reality that there's not anecdotal realities, but it's not so concrete as that study tries to show. And I think that, yeah, reframing the questions that we ask would be appropriate. But thank you for bringing that up.
And I also want to point out that this is another example where well-intentioned people can, in fact, enact trauma on their patients because they're following a system that is race-based. So that individual physician may not have had any issues with interpersonal racism, but they were following a kind of institutionalized racism that they were made to follow because that's how the system is structured. So that's another way, again, that we can all perpetuate racism without even realizing the impact that it has on our patients.
I also think it's, your talk is wonderful. And I also think it's so important to realize that if we're truly going to practice medicine, we want to really figure out what the real factors are. And I mean, you've touched on that as well. So just doing studies on race alone, not including factors of socioeconomic status or, as you mentioned, microaggressions, any of those things is a detriment to all patients, because you're going to miss, it's the red herring kind of factor. You're going to miss what's really important to caring for those patients, regardless of race.
Thank you for that. And I agree, red herring is a great use of that, is a great example of that term. I see a question from Joe Sherman. Are there any advantages to distinguishing race in medicine which advances equity and deconstructs structural racism? Are you asking, like, are there any, if you're asking if there are any examples that you can appropriately or responsibly use race, is that what I'm understanding? And Naomi, you're nodding like you have an answer to this question.
Yeah, so my interpretation of the question, and I could be completely wrong, is that this person was asking, is there any role of using race in medicine and any advantages to using race in medicine? And I would say that there's definitely a role in race in medicine. The key thing is to keep in mind that race is not biological. So as long as you're operating within that framework, I think it is appropriate to collect race-based data on health inequities. Like right now, it's been extremely important to collect race-based data on COVID inequities, vaccine inequities, all of those things. These can help guide policy, but they're on the population spectrum, right? When you look at an individual patient, you can't say this patient is Black or this patient is Asian, therefore I will do X, Y, Z. Race in medicine is more looked at to trying to guide policy and looking at the population, right? What disparities exist, how can we address them? It shouldn't guide individual practice.
Yeah, I really want to echo that. I think oftentimes when we are unsure in medicine of reasons that there is an outcome, we often say, well, we don't know. It could be environmental, it could be genetic, it could be biologic, to cover all our bases. And I think I would encourage us to stop doing that about race. There's been a lot of data in COVID. There have been claims that, you know, Asian people and Black people have different receptors in their lungs and their nares, which is why you know, Chinese men in Wuhan got more COVID than women, or that Black people have more COVID than other people, when it's actually quite clear, I think, to me, that there are many environmental and structural factors. You know, this paper even says maybe it's because Chinese men smoke more, but it could also be genetic, right? And that is really detrimental to this field. And then in the case of racial disparities in the US, you know, we can obviously think about the environmental and structural factors that that marginalize patients of color and further expose them to the likelihood of having COVID and having worse outcomes, rather than some genetic marker in their nostrils that, you know, may play a small role or not. It just really muddies the bigger picture.
So I just wanted to respond to your question with other people's comments, just so that we know what some of the comments are that people typed into the chat. So the question was, what will you pledge or encourage others to do after attending today's talk? And some of the responses was systemically and reliably identify family, social, or financial needs and provide support to help the family with these, so that we are working to help overcome the socioeconomic injustices in our society that contribute to poor child health. Also ask about social determinants of health and consider an individual patient's context when delivering recommendations. Another recommendation was shape EMR at the system clinic level and how we collect and use information. Bringing many to the table when decisions are being made for public health access. Form a parent family advisory group that includes families from wide variety of experiences, backgrounds, and ethnicities. Deconstruct how race is utilized erroneously as a risk factor for different diseases, and being more critical of knowledge, in quotation marks, that leads us to believe a higher incidence of a disease process assigned to a race, to become clear how that information is integrated into our differential diagnosis and discussions.
One other that I'd like to add that can be easily implemented even today is to remove race from one-liners when giving presentations about patients, right? Because again, race is social, not biological, and it often already biases the people that are listening to think about certain diseases as opposed to others, or to guide the way that they interact with that patient. So that's another freebie that you can implement even today as you go off to clinic.
Sorry. No, please, Angela.
One other thought I actually had, and I had meant to say this in the part about genetics, and I just want to be very clear because I often get questions about this, is, why then recruit diverse populations? And I think the answer is, as Naomi kind of said, to elucidate the structural, environmental, societal determinants of health, and there are inequities that we need to study. And also that there is genetic variation across the globe, right? All of us on this call are somewhat genetically different. We're not all the same. And to study a very homogeneous group means that you miss out on diversity. The problem comes when you define diversity into buckets that we as humans have decided are the buckets. It's not to say that there are no genetic variations, that there's not variations that are higher or lower in certain populations. And I think being really nuanced in that, the way that geneticists are, is very important. And I think as somebody who is not a geneticist, I often feel like I only have a lay understanding of genetics. And so really being careful with our language.
I also wanted to echo Tamani's point, Dr. Coker's point about the way that we teach and talk about BMI. That is a very, at least for me, that is something that I work on every single day in clinic when I talk to my patients, especially as I do a lot of well child visits. And sort of what I always take from every time I have a conversation about BMI is to look at my patient. They are right there in front of you. And to look at the chart and be like, this looks bad, as opposed to being like, well, that patient looks great. Like they're eating well, like mom is doing a great job of feeding her child. And this child is running around the room and as happy and as playful as can be. It's about building healthy and strong bodies, not stigmatizing them based off of what is plotted on the chart.
I see a question in the chat from Sarah Rafton. What about stratifying outcomes by race? One problem I have observed is organizations doing that, but not making investments necessary to overcome identified inequities in outcomes. Is stratification merited if an organization will address inequities? I think in thinking about answering this question, I think it goes back to our earlier discussion. It's not necessarily a bad thing to point out inequities by race or outcomes by race. In fact, we need to elucidate inequity and to see that outcomes do differ. But I think the distinction comes in that instead of explaining those disparities with biology, genetics, and inherent cultural quality, I've heard like, oh, in the beginning, like Black people are less likely to get the COVID vaccine because they distrust the system more, right? And instead of doing that, framing it more as the medical system has let down people of color time and time again and built this inevitability of mistrust. And so I hope that nuance, it's really nuanced, but it's really important, is we should stratify, but the reasons and explaining those and further research should be framed less on inherent qualities or biological qualities.
Yeah, and I'll also say that oftentimes when I see these race stratifications, what you see in the commentary is that, oh, they differed by race because of race, right? So there's no like explanation for why they stratified them by race. There's no I think it's a good thing to look for these inequalities, but you can't just stop there also, right? So if you're going to look for inequalities and you prove that they exist, you also have to think critically about ways that you can improve those inequalities. I think there's a lot of people patting themselves on the back for putting out research saying, oh, we found these inequalities in XYZ. But it's one thing to point them out. It's a totally different thing to actually work towards fixing them. So I think it's important for research to point these out, but we actually have to be committed to making a difference.
With a couple minutes we have left, I also see a question about thoughts on how to, I think, diversify speakers and make sure they're not all, from one population. And about access barriers to the COVID vaccine. I think the answer to the first one is that it takes work, right? The people that will be amplified are probably are historically people with a lot of privilege. And I think looking towards like community organizations, really utilizing people who have expertise in social media. I feel like a lot of times like more diverse voices are represented there. And I think just really casting a wide net to find people because they're out there. That doesn't mean they don't have the expertise, they just haven't been asked. Inclusion of race and precepting.
I will also say in terms of finding speakers, to looking outside of academia, right? So one common thing that I noticed at the School of Medicine is that oftentimes they focus on bringing in, only the PhDs or only the MDs from, specific science departments. But you forget that there's entire departments of sociology, social work, anthropology. There's all sorts of people that can come in and speak. And again, to my earlier point that people can study the experiences of minoritized populations. You can study those day and night, read every book. It's not going to beat the expertise of someone that's actually lived it, right? So looking for people that are in the community that can come and speak and kind of deburdening ourselves with the idea that the only worthwhile voices are ones that have, extra letters behind their names.
Yeah, I've learned the most from non-medical professionals as well as people with those lived experiences without academic degrees. I really want to address, I know we only have like 1 minute left, but this question by Hillary Richardson about including race in precepting, giving consideration to cultural or structural factors that could be relevant to treatment. I think it's really important to separate those two, that not every person of color has food insecurity or cultural views of weight and size. And I think that falls into this trap of essentialism. And I think I often hear that. And I think the learning about what used to be called cultural competency has led to a lot of this like delineated thinking. So thinking about like, well, if your patient has food insecurity, they have food insecurity. And you can discuss that when you're discussing them past the one-liner. And it doesn't actually matter what race they are, right? Like not all Black people have food insecurity or have a certain cultural view of weight and size, or other people of color, or just because they're white doesn't mean they don't have those either. And so I think really decoupling those and not using race as a proxy for it, because it's not a very accurate proxy.
And I'll add to that, One hesitation whenever I give talks like these is that I worry that people are looking for a specific formula of how to interact with each patient in terms of getting necessary information and not, perpetuating racism. And there really isn't one for that, right? Each patient's going to be different, the interaction is going to be different. And the key to these questions really is your patient is right there, right? Asking them these questions. What are your relationships with weight? What's your relationship with BMI? What is your experience with food insecurity? Rather than going in and thinking, these are the specific things that I have to kind of fit this person into boxes for. These are all things that the individual patient can answer for you. You just have to be willing to ask and have the conversation.
I just want to say, wow, first of all, and congratulations to both of you for giving an exceptional talk this morning. It is a real privilege to be able to hear you both speak. And certainly Angela and Naomi left their emails on the slides. And so I hope that people will email them if they have any questions. Remember the presentation was recorded. And so instead of passing the slides along, I highly recommend that people send the link for the recording, because I think both Naomi and Angela did an excellent job answering a lot of the questions as well within the chat. And so it would be a great discussion to watch and then sort of talk more amongst your medical colleagues afterwards. We put information, there's still a lot of activity going on in the chat, but we did put information about the 4th webinar. And so please register for that one. It will be just like this one, very illuminating to sort of learn from some of our experts in this field of medicine about how we create institutional change within our healthcare infrastructure. And then we also put in a link for accessing our Equitable Care page. There was also a link about if people are interested in contributing questions to the QBank. And just like Kat said, we are always looking for people to review the information, to add additional questions, and then to struggle just like we have within our group to write good questions, because we know writing good questions and good answers is very difficult when the data that we have is not always the data we need in order to support the work that we are doing. And I think that given that it is 8:02, that is about it for today. Again, we want to thank Naomi and Angela again for doing such an incredible job and just laying the knowledge on us in a very critical way. So I am so grateful for both of you. So thank you. And with that, have a wonderful day at work. Good luck.